Good afternoon. Where are you in the world? We are on to the second webinar of the operative uro-oncology related to bladder cancer. Last couple of weeks back, we have done the TURBT and the various aspects of TURBT. Today we have Mr. Ghulam Mustafa Nandwani, who is a bladder cancer lead at Ninewells Hospital in Dundee, Scotland. And we have Dr. Sarfraz Ahmed. Sarfraz is very well known to the urological community in Pakistan. He has a special interest in bladder cancer and particularly robotic procedures. So we will start off with Mr. Nandwani, who is going to talk about male radical cystectomy. This will be followed by the robot-assisted procedure, same procedure by Dr. Sarfraz Ahmed, and subsequently again the female cystectomy, which is anterior pelvic exenteration. So Mustafa, you can share your slides now.
Okay. Just a second. Okay, so good evening all. So I think I'll present the male open radical cystectomy. So my aim is to tell you about like the steps, and I would be very practical. So there will be only few slides with some photographs, and later on we will concentrate on the video, and I hope that video will work well. So first thing, I think in the radical cystectomy, because I think this is the male cystectomy, and this will only cover the cystectomy part, because we have the other sessions like lymph node dissection and ileal fenway we will cover in that other talks. So positioning wise, this is for the cystectomy. For the male, it's a standard is the supine position where the break is near the umbilicus. Lloyd Davis is when the total urethrectomy is planned, then we can do that procedure. So then we have an access from you can like anal end as well. Incision is usually a lower midline, but it can be extended to above the umbilicus if need be, or sometimes I usually prefer around the umbilicus. Then first step is the extraperitoneal mobilization of the bladder, then identification of the vas, identification of the ureters, and dissection till VUJ. Then identification and division of superior vesical vessels and cutting of the endopelvic fascia and lateral mobilization, DVC ligation, and urethral dissection. And then I go for the posterior dissection and the removal of the specimen. So that's the position. What we are talking about, the standard is a supine with break near the umbilicus. So that opens up the space between the umbilicus and the symphysis pubis. And below is the Lloyd Davis's position. So step one, you can see on the left side, there are two dots above the umbilicus that I usually prefer to mark the stoma. And there are stitches as well, because otherwise the marks can get faded. And on the right, you'll see that's a standard incision. We give lower midline below the umbilicus, and then we proceed as needed. For the identification of the linea alba, I'm not sure whether you can see my arrow there, but just above in the incision, I think that part is missing. There is you can select on the right side, you can see there is a little wood is applied there. When you pull it up, then where my finger is there, that actually tented up. So that's the position where the linea alba will be. And that's where we made the small incision in the anterior rectus sheath, and we will proceed. So once we have opened up the it's like anterior rectus sheath and identified the linea alba, so you will open it up, and then you will on the you can select the next image, you will see that there is something glistening type of the fascia, which is the endopelvic fascia. That you need to cut before you mobilize the bladder. On the left in the image, you see that my finger is just under the incision, where the you can select just under the symphysis pubis and going laterally on both sides, and that's how you mobilize the bladder. So once you have done it, your bladder should feel in your hand. Next is while you are there, you'll push the bladder slightly towards the cephalad end and towards one of the side, and on the other side you will hook, if you can select with the finger, the vas deferens. That's on the right side of the picture. Once you have dealt with the vas deferens, and then what I usually do, I usually identify the peritoneum and open it, and then you can select enter into the peritoneum. Here, I put one finger in alongside it and identify the urethus, which is on the right side. You will identify, and when we have cut in, and then I take a dual. That's an, or you can take anything. People can tie, so that you can pull the bladder towards the symphysis pubis. Next step is when you do the more lateral mobilization, and then you identify the ureters. And while you have identified the ureter, bring these medially, and anything in the lateral, you will find there are vessels, which will be mostly superior vesical vessels, and the clip and cut. You can use either tie ligature, because like lega clips or ligature, whichever you want. Then preferably I try to, before I do the posterior dissection, I preferably try to do the DVC. So then you can select DVC is done. So then at this point, you can select the hemostatic type of the things are controlled. Then before I go to the posterior plane, at that point I cut both the ureters and send for the frozen sections. And then you see the green arrow, that's the plane between the bladder and the rectum. We need to go in at least up to the prostate. And once we have reached there, uh, then we go back towards the DVC, which we all ligated, but this time we will cut and expose the urethra, and then cut and do part of the retrograde dissection and take it out. So now I'll show you the video, and I'll try to explain it at the same time. So this is the same thing, which is like said the incision. And so this is the white thing is, you can like anterior rectus. And this is how we find the linea alba. So that's an extraperitoneal space we have found. And this is the the transversalis fascia we are cutting. And now this is the lateral mobilization. So you see that's a hooking maneuver. So that's how you find the vas. And then once you have cut, have the vas in your hand, then you can cut it with the ligature. And this is, you can like opening of the peritoneum. So my hand's there, and then both sides there. So this is the urethus, which is in my hand now. So I use the ligature. And at this point, I usually extend the incision slightly to the umbilicus. This is the posterior part. So now that you see the bladder is, you can say like, so these are the lateral folds of the bladder, which we are cutting. And this is the ureter, which we are identifying. So red, I use it for the right side, and you can say like, and blue for the left side. And this is the endopelvic fascia on one of the side. You can see, I think the view is not great because this is an open. So, but I think that I put my finger there and then open it more and up to the apex as much as possible. So this is on the left side where there is a sigmoid is attached there. So I'll just mobilize it slightly. Sometimes you may not need to mobilize it. So now I have exposed the vessels, and this time the left ureter, I will say. So on the right of the picture, you'll see the psoas tendon, iliac vessels. And this is the left side of the endopelvic fascia, which I have made a nick. And these are the ureters, which I use, send it for the frozen section. So in this way, double clips towards the distal end. And then there's one is the, you can say like a distal suture. That's for the identification for the proximal or distal end. And then there's a stay suture. So you see that once this is cut, the suture will stay in a distal position. So the ureter is cut, stay suture is there. Now you see that the posterior part of the bladder, where I'm cutting you can see like in the pouch of Douglas, so the peritoneum which was reflecting is cutting. So now that part's done. And at this point, I reflect it downwards and create a plane between the posterior part of the bladder and the rectum. And the best thing that you can put, okay, so this is you can say like the apex, which I'm freeing, and these are the puboprosthetics, which I'm cutting to get the more mobilization. Sorry, the views are not very good. So at this point, use the Babcock, and then you pull with your two fingers bladder towards you, and then you do the test. So these are the DVCs which we have tied now. So now this is another suture you will see, which is the proximal one, which is the back bleeding stitch. Now I use the ligashore, and the trick is press the bladder down and horizontally cut it. So you need to lift the DVC up. So once you have lifted the DVC, you can see there is you can say like you can say like right angle is under the ureter, and I'll make a nick there. So once you have made a nick there, you'll see there's a catheter there. So you'll put a long clip and then pull this. Okay, you can see this now. You pull the clip, and at this point, what I do, I usually put the two lega clips on this so that the balloon remains intact. And then I pull as much as, and then under vision, I cut the posterior wall. So once you have cut the posterior part, and then you lift it towards the cephalad. And these are the neurovascular bundles you can say like cutting. If you want to spare it, you can spare it as well. So both sides in the middle, and then you can say like you'll see that this like a bladder is coming out. Okay, so this is the prostate. This is the urethral end, which is cut. This has a half of the bladder was full with the tumor. This is the, you can say like posterior parts. These are the ureters. Okay, so now at this stage, what I do, I'm not doing the orthotopic in this one, but at this stage, what you can do if you're planning to do the orthotopic, you can take the stitches at this point. So two lateral, one interior, or you can say three, and you can say like 11 and 12 o'clock, and then 7 and 5. So that's how you do it. But that was just for demonstration. But what I usually do once I have done the the specimen is out, so I usually take the Prolene stitch and close this gap. Is preference. Some people use it. This you can say like a urethral catheter as a drain. That's acceptable, but I prefer not to use it. So I just close it, and that's how we create it. So other thing you see that this is I'm putting the catheter in there. That's the jacuzzi test. Sometimes when I'm worried, so I fill the bladder with the cavity with the water, and then we put the air through the catheter. If there are no bubbles, it means there is no it can say like what you call it, rectal injury. Okay, so I, I think that's so now I'll stop here, and if there are any questions or anything, or if you want to watch it again, I can play it again.
Thank you, Mustafa. I think that's a good demonstration of the surgical technique of doing a open radical cystectomy in male patients. Please, we'd like to make it as interactive as possible. Those who are doing it or those who have seen it, the technique varies in various ends. What Mustafa has described is a standard way of doing radical cystectomy. There are various different techniques that people use. Some people like to do the lymphadenectomy was done as a first step that exposes the vessels and make the early ligation of the anterior division of the internal iliac possible. Uh, I did this for a very long time and then subsequently changed because now I mostly do extraperitoneal radical cystectomy. So there are a lot of variations. So please discuss your own way of doing it. If you have any questions, if any of these steps are not clear, Mr. Mustafa will try and explain that step as well. So, are there any questions, any comments? Okay. Seems like it is absolutely clear, Mustafa. People can go and will do it tomorrow. One
All
case.
right. Okay. I'm
Okay.
glad I'm
Great.
trained. Okay. So I think in the chat.
Okay, Mr. Mazhar Sheikh, our non-muscle invasive brother, is asking about prostate sparing.
Okay. Prostate sparing. So I think, shall I just stop sharing now? Or
Yeah, I mean, it keep running on the
okay.
background.
Keep running. Okay. Okay. That's fine. Yeah. So, so prostate sparing, yes, I think I don't do it and I have not got a chance to do it. The reason being because prostate sparing, because there is a 25-30% people they get the prostate cancer, not the bladder cancer in the prostate, but the prostate cancer as well. And usually that's why we don't need to leave those organs which can turn into the cancer and give a problem later on. However, those who are very keen for their erectile function and if they are having an orthotopic bladder, sometimes people can leave the prostate or at least the apex of the prostate so that the nerve preservation is much better. But obviously, there are consequences. Is a cancer you have completely taken out or not? So these are the things. But I think majority of the people they do you can say like they take the prostate as well at the same time. That's I feel. Mm.
Yeah, I mean, the standard procedure is radical cystoprostatectomy, prostate sparing, and if you look at the guidelines, it's very clearly indicated that genital organ sparing radical cystectomy is an exception. And in very selected patient, you can do prostate sparing, which essentially is a prostate capsule sparing procedure, which apparently will have some preservation of the sexual function, the better continence if you're doing. But generally, prostate sparing is not performed, or if it is performed, it has to be after an extensive workup and explaining all the consequences. We have seen about 5% incidence of an incidental prostate cancer in patients who have a radical cystoprostatectomy for bladder cancer. So that's another something that needs to be careful about.
Mhm, mhm.
So, okay. Right. I think, let me see if there are any further comments. No, no, there are none. The whole concept started in Mansoura, Egypt, where the schistosomiasis afflicting younger population and women, especially in their in the productive years of their life. So genital sparing radical cystoprostatectomy is done after extensive workup. Okay, so right, I don't think, Mustafa, we have any further questions or comments. If there are one, we will take it on your next presentation. So may I request Dr. Sarfraz Ahmed to please share his presentation?
Thank you, Prof. Ahmed. I'm just sharing now.
Sure, thank you.
Can you see it?
Yes, perfect. Thank you.
So good evening, everyone. I'll be talking about robotic-assisted radical cystectomy. I know our main focus is a technical aspect of this surgery, but I'll just give you a bit of background. Robotic radical cystectomy for bladder cancer, what evidence we have, and what technical steps are applied for the robotic procedure, which are different from the open one. And I'm thankful to Mr. Nandwani. I think he has covered most of the steps which are open, so you will get an idea how robotic different from open. So whenever we do operation for any cancer, our main goal is that we want to cure the disease. We want to have a procedure which is a safe procedure, provide patient a faster recovery, less complication, and better functional outcomes. And same apply for cystectomy as well. But cystectomy is a complex operation, and largely because it is not one operation, it's actually a combination of 3 operations. We do cystectomy, we do lymph node dissection, we do urinary diversion, and then on top of this, like procedure is different for male and female. Additionally, we see that we do this procedure for aging population. Patients are usually older with multiple comorbidities. Procedure is long, and there is also disease-related factor like locally advanced. So for a long time, open has been a gold standard and it still is widely used in, if you look at global perspective, the open procedure is widely used, but over a period of time, we are moving toward minimal invasive. For cystectomy, laparoscopy was introduced in 1990s. Didn't take off much because of the complexities of the surgery. Then robotic came into picture over 20 years ago. And since then, it has been adopted in various centers around the globe. So, but we have to ask the question, like whenever there's a new technique, why we need to make change if something is working well? And if we have something new, it should be better or at least same as the older technique. We should be able to provide better perioperative outcomes, better functional outcome, and cost and the training aspect should be considered as well. The robotic radical cystectomy since its start in 2023 has been widely investigated, widely reported. We have many high quality evidence, which is ranging from case series to comparative studies to randomized controlled trial and systemic review and meta-analysis. So I will go through some of these evidence briefly before we can go into surgical aspect. The first landmark paper, which was reported in Lancet in 2018, was an American study, which was a randomized controlled trial between the robotic assisted radical cystectomy comparing open. It was multi-center trial, including 302 patients, and primary endpoint was 2-year progression-free survival. The only drawback in this paper was, which was criticized as well, the patient who were included in the robotic arm, they have extracorporeal urinary diversion, which lost the whole advantage of a total laparoscopic or minimal invasive surgery because it's a combination of robotic part and also the open part. However, this provided important information that the oncological outcome and recurrence and survival was comparable between 2 arms. Robotic was better in terms of less blood loss, less transfusion, and a shorter length of stay in the hospital. But operation time was prolonged for the robotic cases as compared to open. So they found like it's not inferior to the open surgery and provide comparable oncological outcomes. So to overcome the idea of that, like because if we compare the total intracorporeal approach, like where conduit, cystectomy, and the lymph node all done by robotically without need to make a bigger incision. So this study was led by Jem Cato in UK study, it's IROC trial, where they compare total intracorporeal cystectomy with conduit diversion and comparing with open surgery. And this was a head-to-head comparison of minimal invasive with open surgery. And this study also identified that oncologically both are same. Complication-wise, the important thing which was a significant was observed that the 90-day mortality and out of hospital was in favor of robotic cystectomy. In terms like the patient who has a robotic procedure, they stayed lesser amount of time in hospital at the end of 90 days, and also there is morbidity was less as compared to open technique. So this was important finding from this trial. And the most recently, we have another trial from Rome. It is a single center trial. They also again clarify this 2 years outcome shows oncologically things were similar. However, blood transfusion and blood loss was less in a robotic arm group of a patient. So they summarize that again, complications were comparable. 3 years on oncological outcomes were comparable in both groups. Transfusion rate was less than 50% as compared to open. Better image perception due to minimal invasive nature of the robotics procedure. And cost was more in a robotic cases. It favors open surgery. Then we have a meta-analysis and systematic review of 8 randomized controlled trial, which highlight that operation time was consistently high patient who is going for robotic procedure. Blood transfusion was low in a robotic arm. Bowel recovery, positive margin, lymph node yield, they were all equal. Length of stay favors a robotic procedure. So this meta-analysis also favors the thing which has been noted in a previous one, that transfusion was less, oncological outcomes was same, but OR time for the robotic is longer and the cost was higher for the robotic procedure. On the basis of these evidence, we can see like it's not inferior to the open surgery and providing equal oncological benefit. And there is some early perioperative benefit and mortality reduction as reflected by IROC trial. So most of the guidelines now recommend that patient need to have a discussion about the robotic cystectomy, and it should be done by a center which has a high volume of cases done to get better outcomes. Due to these positive benefit of robotic surgery, if you can see the global trends, like initially people were a bit more skeptical about adopting this technique, but over a period of time, both across America and Europe, there is an increasing trend of having robotic procedure done for bladder cancer, and there's a declining trend in open surgery. And similarly, once the expertise has enhanced, the people are adopting totally intracorporeal. Initially, people were doing robotic cystectomy and lymph node robotically, and for the conduit, there was doing extracorporeal. Now, all are most center are doing intracorporeal. So these evidence suggesting that robotic has a role in bladder cancer treatment. So next few slides, I will explain the technical aspect of the procedure, how it is done. Again, there are many different techniques used by people. So I'm going to have a standard robotic technique using a Da Vinci. We have a different platform, so there will be slight variation if you're using the different platform. My focus will be on the steps which is used for Da Vinci. So there are 8 steps for male and 8 steps for female robotic cystectomy. So we normally start with the ureters. For male, posterior dissection, lateral pedicle control, drop the bladder, DVC control, securing the urethra, and then retrieval of specimen. In the time of ureter isolation, we have to look after the ovarian vessels, ureterosacral ligament. When we do posterior dissection, the things are different, that we need to open the vagina and then drop the bladder, and the specimen can be retrieved through the vagina. The vaginal closure will be required in a female patient. So this is a standard position, like steep head down. So this is position which I use for an older version of Da Vinci, which is SI. In newer version, you don't have to keep the legs in the sport. You can leave them flat on table and do the side docking. But for the SI one, this is the position we use, which head is steep down and the legs are well supported. And make sure you protect patient from the pressure source and slipping as well. So we use this mattress which will prevent slipping of the patient. The standard port placement is the 6 port placement. Now, this is same for any version of the robot. So I start normally first port, which is the camera port, about 3 centimeter above the umbilicus. I use Hassan technique for this one, and the rest of the ports are inserted under direct vision. 2 ports on the right side and 3 ports on the left side. The 2 are assistant ports, and I use 12 millimeter ports. These help to use staplers for the unidiversion. So the first step is to identify, this step is different from the open. If you select open, we go straight to mobilize bladder. But in robotic case, you can imagine patient is head down. So we are looking directly into the pelvis. We don't drop the bladder until we have done posterior dissection and also identify the ureter. So this step is different from the open. So bladder will stay as it is. We'll start from the right side. Incision is made on the right side of the ureter, just above the peritoneum. The incision should be made carefully to avoid any damage to the surrounding structure, especially the iliac vessels. And the split and roll technique help. The care should be taken that the mesentery of the ureter should be preserved as much as possible. And once you have identified the ureter, we just proceed distally as below as we can go, reaching to the bladder. So the right side, usually not much length is required for the robotic procedure if you're doing intracorporeal diversion. But again, we'll try to go as distally as we can go. We apply clips on the distal part of the ureter, and it is divided into ureters. So the question about where to divide is that we usually go as distally as possible, and we divide at this stage and we clamp it. This is my standard. Some people leave it open, but this will cause a lot of urine leak here. Frozen section has been debatable. I normally don't do frozen section until we're doing a neobladder, then I'll send the frozen section. But for the standard ideal conduit, we don't send a frozen section routinely. But it can be sent if there's any concern about upper tract disease. After doing the right side, then we'll move on to the left side, which we have to mobilize the sigmoid and repeat the similar step, which we have done on the right side. So special care need to be, special attention to be paid that we will not damage the iliac vessels. Bowels on the left side, especially sigmoid. Sometimes if there is a diverticular disease, you need to be careful when you're mobilizing. Length should be adequate, especially for the left side, because you have to swing the left ureter to the right. So after you have mobilized the ureter, the next step is we have to create space posteriorly. That's a posterior dissection. So the beauty of a robot is that you can do this under vision. In open, mostly it is done with a feel. You can't see the posteriorly, but a robot provides you a very good view. You have to use your instrument clearly to develop a plane. You will open the peritoneum, giving the incision in the peritoneum, which will allow you to reach to the adenovarious fascia, and then you lift the bladder and prostate from the rectum. In some patients, the plane may be not that friendly and you may not be able to see. So the easy trick in those cases is that if you can identify the vas and follow the vas medially, it will lead you to that plane where you need to make incision to make your dissection. A special care should be taken in this area not to use diathermy. The rectum is not far away. The most of the rectal injury will happen here. And try to stay as above as possible. You need to use your assistant or your fourth arm to retract rectum back, and slow, blunt, and sharp dissections are used to keep lifting and the prostate of the rectum. So once the posterior dissection is done, so you can imagine like your ureters are isolated, the posteriorly bladder is mobilized. So then we pay our attention to the lateral dissection. We hold the right side of medial umbilical ligament and retract laterally, and then make an incision lateral to this one and extend this deep into the pelvis. So this should be done atraumatically. Inferior epigastric vessels sometimes can get damaged if you're very deep. They need to be avoided. The incision is made and then it's mostly bluntly, and sometimes it's a sharp dissection. You can keep following that line and you will reach into the pelvis. You can see the lateral pelvic wall in this picture, and the bladder is now reflected medially. So bladder is all medially. Your lateral pelvic wall is here, so you need to avoid damage to the external iliac vessels. They are not far away from here, and the obturator nerve will be just a bit deeper to this area. So you can see this one, there's pedicle will be in your hand now. This will be next step. This, once you have mobilized posteriorly and laterally, all you left will be this pedicle, which you need to control. That will be the next step of your procedure. So things become easier because then you have a very good space laterally. You have mobilized the bladder posteriorly. You use your instrument to lift from the bladder from posteriorly and use your other arm to make a space for your assistant to apply hemologs. So this is straightforward procedure that you just need to develop planes, ask your assistant to keep going distally. So nerve sparing again can be done. So once you reach near the prostate, if your patient are suitable for nerve sparing, so you can save the neurovascular bundle as shown in this picture and reflect the prostate. Prostate as capsule sparing can be done in a selected patient, as we discussed just short while ago. So that this robot can provide you better visualization, so the nerve sparing can be achieved in these cases. So once you have done both pedicles, then the next step will be like the bladder will be just hanging with anterior uracular attachments. So posteriorly and laterally is fully mobilized. So then it become kind of straightforward that you divide the urachus as near to the umbilicus as possible. Keep doing this. You need a sharp dissection in this area, diathermization to stop any bleeding, and you need to continue doing distally till you reach to DVC. So DVC in robotic cases we slightly modify that we now moving toward like mostly we can divide DVC at the cold cut. It will bleed a little bit, but because of pneumoperitoneum, it will stop quickly. Very limited blood loss. If there's a worry about the bleeding, we can put a suture before dividing the DVC. But most of the cases we divide is the cold and then oversaw at the end of the procedure. After dividing the DVC and opening endopelvic fascia, you will directly go in the urethra. We need to get a good urethral mobilization as shown in this picture, that you have to go posteriorly, make sure you're lifted away from the rectum. And if you're going to do a new bladder, you need to have a good length as well. So there was a criticism on the robotic that there is a risk of spillage of the cancer cells. To avoid that, so once we have urethra fully mobilized, we apply a very big hemolog. After retrieving the catheter, book a hemolog toward just at the apex of the prostate. This will prevent any spillage. And once the clip is applied, then you can divide the urethra just distal to that clip. So specimen will be free then. It should be placed in a bag, and a retrieval should be done either by so normally I leave it there. We'll do the lymph node and alveolar conduit, and at the end of the procedure, we extend one of the assistant size incision to giving a 4 to 5 centimeter incision, and to remove the specimen. This is one patient shown how the incision will look after 12 months of surgery. In female patient, there is only a few things that are different. I'll just quickly go through. I know Dr. Nandwani will explain a bit more about the open. The steps are same. You go for the ureters first, and when you're doing the ureter dissection, there will be ovarian pedicle. You need to secure those. We need to mobilize the ovaries. We need to mobilize the ovarian. They need to be secured with the clips. We need to mobilize the uterus. And once uterus is uterine vessels are secured, uterus is lifted up with your instrument. If it's very bulky, you can put a stitch as well to lift it. And at this stage, the good tip is that to put a sponge on a swab stick inside the vagina and guide where you need to go. The incision should be made at the time where the uterus is finishing and near the posterior wall of vagina. Once you make incision on that, this will allow you to see your sponge. And after making that, this is sponge visible. After making that incision, you can carry on the dissection using hemostatic. You can use this ligashore or clips as well, because this area is quite vascular. And keep extending and taking the anterior lip of the vagina with your specimen. So once the specimen is released, the urethra is divided the same way as for the male. And most of the female, like we put the specimen in bag through the vagina, and the open vagina will remove the specimen within the bag through vagina, so without extending any skin incision. So in summary, we can see that the robot has been used multiple procedure in urology. It has a lot of advantages for surgeon. We have a very good 3D magnified view, wristed movements of the instrument. We have this instrument is very intuitive. Tremor cancellation. Comfort is always important because you can all imagine cystectomy is a long, tedious operation. The robot has taken that tiredness away. You are not as tired as with the open. Training is also something is easy. The learning curve for the robotic cystectomy is shorter than the open. You need to do a lot of open procedure to achieve the competencies in robotic because you're seeing things as well as you're doing. The training aspect is a bit more shorter. The learning curve has reduced for that reason. So what is the benefit for patient? We have multiple evidence now. There are few things which are confirmed in multiple trials. Few are still a bit doubtful, but overall we have less blood loss, shorter hospital stay, equal oncological outcome, less complication has been reported in some trials, and less pain for patient. So these things favors that patients and surgeons are getting benefit by doing a robotic procedure. At the end of the day, we just need to make sure the robot is only a tool. Wherever you're working, whatever best facility you have, either or expertise you have, you need to offer to your patient. Also, we need to be mindful technology will keep advancing, and we need to be open to adopt wherever is feasible. And best thing is that we need to train ourselves best to have a best outcomes for our patient. Thank you very much.
Thank you, Sarfraz. Wonderful, very balanced, and very nicely explained all these steps of the procedure. And as you can see, as I was mentioning earlier on as well, that there are more than one way of doing a surgical procedure. And you see that robotic cystectomy is not a duplication of what we do in open surgery. The approach is slightly different, and that is adapted to ease the procedure. I think one of the major advantage is to the surgeon, particularly if you're working at a high volume center. Cystectomy is a very taxing procedure, and particularly in male patients where narrow, deep male pelvis make it very difficult. I still have callus on my left hand because most of the time it is in the patient doing most of the surgery, particularly periprostatic at the apex of the prostate, using your hand rather than vision. So that's a definite advantage, as mentioned by Sarfraz as well. Obviously, the first 4 weeks are much better following a radical robot-assisted procedure in terms of complication, blood loss recovery. Typically after 4 to 6 weeks, there is not much difference, at least so far not shown. But I'm sure there will be, with technological advances, significant improvement in that aspect as well. So if there are any questions to Dr. Sarfraz, I don't see anything in the chat box as yet. Okay, please feel free to write questions to the previous presentation and this presentation when we move on to the next one, and we can take your questions in the end. Sarfraz, one question about this frozen section. You do your dissection, you said that you go down distally as much as possible to obviously have a good length for easier conduit formation, and you don't do frozen section. Any idea about what is urethral recurrence rate in your series?
So far we have one positive case in my Scotland series. Like there was more than 100 patient, which has CIS in the final specimen, and this has not changed any kind of management because she has no kind of recurrence afterward. This was a distal end was involved. I don't see like much, and I think the problem is with the frozen section is that it's not reliable. What you will do, like most of the time they say it's a dysplasia. You can keep going higher as much as possible. For the new bladder is the only thing which I feel there may be some benefit because dealing any upper track after the new bladder will be very difficult. And in those cases, we want them, like if it's a positive frozen section, we may go for conduit rather than new bladder. This is the only thing I do. I don't know whether if you do anything different from your experience.
The issue is that for new bladder, you can divide your ureters quite higher up because you have a chimney available, depending on what kind of procedure you're performing. But for Studer bladder, you have a nice chimney and you can divide them at the pelvic rim even, and there is no issue. For ileal conduit, I particularly like to spare significant length because I do retroperitoneal cystectomies, and it is difficult to really mobilize those ureters without opening up the peritoneum too much. So the technique is slightly different. But I think what works in your hand is probably better than anything else. Mustafa, you have a
Sorry,
observation?
do you send a frozen section routinely for ileal conduit
Yes,
as well?
yes, always.
Okay, okay, good. Mustafa, I don't know whether you send or not.
Okay, yeah. So I think from our side, I usually do the routine section. The reason being because when I started, I was doing the prospective audit. So when we did the audit, so we wanted to see that what are the results. So what we have seen, and we are still continuously doing the audit. So our results shows that 8% were positive, which we made negative after the frozen section. And there were 3 or 4% where we required to do 2 or 3 frozen sections, which required extra length. So the ureter which I cut, it's just around the, you can say like not exactly at the UVJ, so few centimeters above, so near to that, you can say like where there's like a pelvic brim is there where I cut and then send it for the frozen section. Accuracy wise, we saw 99.7% accuracy rate for, you can say like when they say it's a positive or not positive. That's what we have. So I think our pathologists are quite confident and they, you can say like we have no issue. So I think that's why. So in conclusion, if I had not done the frozen section, these 8% would be positive overall. Figures might have dropped down now, but it's still 6%. Secondly, there was when there is a suspicion, so I change the technique. So I go more higher and higher. So in 6-7% more, I needed to change the technique. And so far, we have not got any ureteric recurrences, means that ureteroileal recurrences where the frozen sections were negative. So in our previous thing, where same thing was there, where the frozen sections were not sent, there was a 6% recurrence, and they all the 6% were positive and they all had a recurrence at the ureteroileal junction. So that's what our results are. And that's the basis for my routine frozen section strategy.
Thanks, Mustafa. Sarfraz is a question from Saqib Javed about what is the number of cases after which you can mostly credential your trainee or a fellow for robot-assisted cystectomy. So what's the learning curve like for robot-assisted procedure?
So Baus has given some idea, like there's a guideline for the robotic training. They suggested a number 30, but this is after you're trained with the robotic prostate. So that was initial data. To train in a robotic is around 100, which I can remember. If it's not 200, it's around 100, yes, and then 30 robotic cases. Most of people, if they're not, I think the ideal is that you start doing robotic prostate to get some competency in the robotic prostate, then move to robotic cystectomy. And the 30 cases are required then when you can move. Most of the people I've seen, like after doing 10 cases, they start doing intracorporeal. They do 10 to 15 initially extracorporeal, then move to intracorporeal.
Thank you. Mustafa, you can share your slides.
Okay.
Sarfraz, moving from Europe to Middle East, have you seen that you're doing more radical prostates or radical cystectomies in your hospital?
So that's a very good question. I think in this part of the world, like patient are very reluctant to have pelvic oncology surgery, especially if it's related to the prostate and bladder. On comparison, we have done more prostate than less bladder. They like to preserve their bladder, most of the patient. In terms of overall robotics, we have done more upper tract robotic than the pelvic surgeries. And the incidence is also slightly different, and the population is also less as compared to Europe.
Thank you. Mustafa, please proceed.
Okay. All right. So I think this is like mostly like a similar format as the previous presentation, but this time is for the female open radical cystectomy. So I think the better term is actually anterior pelvic clearance, and these are the steps. So positioning wise, slightly you can say like different. It's by standard, it's like a Lloyd Davis's position because we need the access to the urethral end for the urethral dissection. But nowadays I have switched to the supine with a split leg, where I do all the procedure as an antegrade approach. So I'll show you in the slides. Second thing is when you're doing it, so in here, one thing's different that you need to put the swab in the vagina, which we usually put it with a hebetine or whichever you can select, use the betadine as well. That will be more beneficial for identification for the vaginal wall when you'll do the surgery. Incision wise, there's no difference. Same thing like a lower midline infraumbilical, but in the females, people have used the phenastine incision, but I usually use the same, you can say like lower midline and infraumbilical. The advantage in the female is that their skins are slightly lax, so most of the time you can remain below or just at the umbilicus because of the laxity. Second important thing is that the female pelvises are wider, so I think there is a more exposure and technically slightly less challenging. Again, this extraperitoneal mobilization is the same step. Identification of the round ligaments, that's a counterpart of the vas difference, which and identification of the ureters and dissection up to UVJ. And here, important thing is that in male, it's more straightforward, but if you'll see that in the females, the uretrovesical junction slightly bends, you can say like posteriorly and laterally. So it needs to be lifted up properly when you will do the vaginal dissection or the vaginal cutting. So you don't need to leave the uretrovesical junction. Then identification of the superior vesical vessels, and here you will find slightly more branches which will be going to the uterine and paravaginal vessels as well, cutting of the vaginal wall, and then continue as an antegrade dissection till the urethra. Urethrectomy part, you have an option. Either once you have done the dissection up till the apex of the bladder, or the you can say like urethra, so surgeon can move because like between the legs and do the resection of the urethra from that part in the retrograde fashion, and then you pull it out. Or other things that you can continue and just like go under the symphysis pubis, and I'll show you my trick. And then you can do it in the same way without changing your position and in the supine position. And then the closure of the vagina. When you do the closure of the vagina, I think is slightly, sometimes it becomes challenging because if you don't leave the too much vaginal tissue, then you'll struggle. And there are techniques, either you can close like a box or a pencil. So in this, the standard position, if you see that on the top left is the Lloyd Davis's position. So that's for the standard. And the lower right, that's the split leg position where it will give you the access to the urethra as well, swab. And that's the position which I have changed now. Incision wise, it's the same incision, same thing, so I won't waste time on this. The only thing I forgot to mention in the last time, you see on the right side, we usually, you can like cut the subcutaneous tissue on the rectus sheath to expose more rectus sheath. The reason being is it helps you in closure so you can identify more properly. And after the operation, we usually do the rectus sheath catheters for pain relief, which is the local anesthetic. So then we have a more space available and we can put it under direct vision. This is the same thing as identification. This is no different. Again, this is not different. Same thing up till the urachus. But on the right side, if you see, in this region, this is the round ligament. So that's round ligament. These are the ovaries and etc. So we'll see. And so once you have, you can say like open the, you can say like peritoneum, etc. So you see that you lift up the uterus. And here, when you lift it up, this is the vaginal line. You see the two fallopian tubes. These are the ovaries, and these are the, you can say like round ligaments there, and these are the broad ligaments. So these all need to cut, and underneath there will be the gonadal vessels, which we need to cut because in females we need to take out the uterus, fallopian tubes, ovaries, and you can say like a part of the vagina. So that's called the anterior pelvic clearance. However, currently there are options of the vaginal sparing, uterine sparing, depending on the age of the patient and requirement of the patient. So on the left side, if you'll see, there is something like protruding there. That means we are pushing the swab on stick, and it means that we are identifying the vagina, and then we'll open the cuff like this. So then, and we'll go into this direction and this direction. So on the right side, you can see the vaginal cuff is open, and we have lifted up the bladder, and that space is more available where there's a suction tip is there. So peritoneum and excision. So I think the slides are slightly there and there. So I think this should be before. So peritoneum opening and urachus part, that's fine. So there is not much difference. And I think what I will do, I'll start, you can say like this, you can say like a video, and then I can explain you same thing. So in this video, the incision part is I have omitted because this is to cut short the time. So if you see, this is like so this is the urachus now. So that's have taken, and so I use the N-seal device. This is the laparoscopic one, but I use it in the open surgery, so I'm used to with this. And that's the view. So you're saying that below these are the ovaries, fallopian tubes, and there is a pouch of Douglas. You are saying, and now you will need to hook it. Okay, so your fingers, when you hook it, you will find these are the round ligaments, and then there is a broad ligament as well, which is going below. So you need to cut to get a more exposure towards the lateral side. So now in the hand, there is you can say like gonadal vessels. So before I cut, I usually put the two lega clips on top, and then one at the distal end, and then we cut it. It's up to you. You can tie these as well. So the right one's done. So then it means the ovary and everything is in detached. And now you can see the ureter is just below this, which is vermiform. Okay, so identify the ureter at the same time. Right, the red sloop, I put it in, and then pull it medially. When you pull it medially, your vessels are exposed, which are laterally, and then you will see that there are, you can say like uterine vessels, and these are, you can say like, I think these are the uterine vessels, and there is another one, you can say like the superior vesicle. You see, this is the junction, uretrovesical junction. So when you cut it, and then you can see there will be some more vessels there. Yeah. So that's another one. So I usually use the gold hemolog, which is more broader, and I use the laparoscopic instrument, so that I think That's what I'm used to, so that I can work from the distance and my assistant can see. This is on the left side. So same principle, what we'll do, same thing. These are the gonadal vessels there. So, and this is the ureter on the left side, which is there. And again, you can say like this is the, you can say like a uretrovesical junction. So sorry, that's not the uretrovesical junction. This is, you can say like this is the ureter, which is I have cut in and we have sent for the frozen section. So see this area, there is a, you can say like the vaginal tissue. So when you cut it, then you can see the swab inside. This is the swab. So now this is the safe, and then you cut it. So you see this area on the lateral side there, this area, which we need to go underneath it and lift it up, because in the female the tissues are lax due to the previous childbirth, so these sag down. And if you won't do this, you will leave the uretrovesical junction there, and that can turn into the cancer later on. So both sides go side by side anteriorly. So the anterior vagina is attached to the bladder. So now you can see, I'll just stop it for a minute here. I'll just slightly go back. Sorry, I'll just. Okay, so you can see there is a catheter there. What I usually do at this stage, once I have reached to the apex, I put my finger there and then pull the catheter inside. So actually the urethra meatus is turning inside, and then we make a, you can say like some cutting there and then push it down. So actually the urethra is peeled off from the under surface of the symphysis pubis, and then it's coming inside, and then you cut it. So that's, I will show you then. So now you can see this is the catheter which I'm pulling it in, and then as a, you can say like when you pull it in, it becomes like a U, and then you cut on the top of it. And then this is, so it's a, yeah. See, so this is the catheter which is there, and now I'm behind it. So that's the urethral meatus, which was at the vaginal end. It's inside now, and then you cut it. Do the dissection on the both sides. I'm using the N-seal, which I prefer. You can use any device. See, this is the urethral meatus, which has intact, urethra is intact, all intact. And this is the, you can say like, so now you can say like closure of the vagina. What happens if you just try to close there and there, you might leave a gap. So what I do, usually slightly in a L shape. So one corner there, one corner there. So this gap's closed. And then you come down posteriorly and anteriorly and then meet in the middle. So then the vagina is closed in a longitudinal fashion. If you want to do the, you can say like vaginal sparing or uterine sparing. See on the under my hand, there is a bladder, and this on the right side, there is a uterus, and this is the plane in between that. That's you cut it and then make a plane in between that. This is the same approach like when you do for the, what you call it, vesico-vaginal fistula type of a thing. So when you pull it, it will leave the vagina intact, and then you can lift the bladder, particularly if the bladder tumors are anterior wall, small volume bladder tumors, and patients are young. It's, you can so like leave the female genital organs. So if you see, this is, you can say like the specimen which we have taken out. So that's the bladder end, urethra. And then there is a, on the right side, the clips you are seeing, these are the ureters. Double clips are ureters. This is the left side of the double clip. And this is the cervix, it's complete cervix. And this is the catheter. And this is all done. Yeah. So I think I'll leave it in, and I think the presentation's finished. I'm happy for any questions if you want.
Okay, thank you very much, Mustafa. I think very nicely demonstrated by both of you the technique of radical cystectomy in male and female open and robot assisted. And I'm sure that our audience really benefit from this presentation. You probably may need to go in to Pause Karachi website and maybe have a look at a couple of times. If you have any questions, please forward and we will forward it to Dr. Sarfraz, Ahmed and Mr. Mustafa about the steps of techniques, and they can clarify. Because we are running short of time, I think we have to conclude this evening's session. Just a reminder that next week we are covering upper tract urothelial cancer, the surgical aspect with the nephroureterectomy, the cuff, and some aspects of the lymphadenectomy. However, we will be starting a little earlier at 6:30 p.m. Pakistan Standard Time, which would be very different in various areas, and we will send WhatsApp about the times in your region when we advertise for next session. So thank you very much. Really appreciate both the speakers and their fine demonstration of technique of this complex surgical procedure. And I'm sure all of you would have really benefited from today. Okay, have a very good evening and a good weekend.
Thank you. Allah Hafiz.
Allah Hafiz.